Welcome, folks, to an interview with Dr. David Hoyt about the new Cancer Surgery Standards Program. I'm Heidi Nelson, and I am the Medical Director for the American College of Surgeons Cancer Programs. And we're delighted to have a new program that we're launching this July. And who better to introduce and discuss the programs than our Executive Director of the American College of Surgeons, Dr. David Hoyt. And Dr. Hoyt, many of you may know, was previously at the University of California, Irvine, where he was the John E. Connolly Professor of Surgery. He was chair of the Department of Surgery, and he was executive vice dean for the School of Medicine. A lot of hats to wear, and then he came to the college where he's been since and has done a lot to help promote this new program. So we're delighted that you're with us today, Dr. Hoyt, to talk about the Cancer Surgery Standards Program.
Good afternoon, Dr. Nelson. And I want to, first of all, before we get into the topic at hand, congratulate you on what you brought in leadership in cancer to the American College of Surgeons. I think everybody knows Dr. Nelson's been with us in that position for about a year, and the program we're going to talk about today, but many, many other things, is going to take us into the 21st century in cancer care for our patients. So congratulations.
Thank you very much. So we'll get started on some questions. So the college has really been defining standards for nearly 100 years, but the standards that we're talking about are more specific to the actual conduct of cancer surgery. And that's relatively new. In fact, I'm not aware of others having put out such standards. So in your opinion, is having surgical standards in keeping with the college's commitment to improving the care of the surgical patient?
Yeah, it's really a fundamental philosophical question as to what a professional organization is. And the American College of Surgeons, to maintain its relevance and to maintain its voice with the American public, with the profession, to earn the right to be considered a profession, we have to have something that we produce that's of value to humans. And in surgical care, our standards programs and our education have really led the way in that regard. The standards programs go back to the original hospital standards for what a hospital should be able to do and how one could practice in a hospital, focused in particular, in our case, on surgical care. But it's that program that started about 100 years ago that ultimately evolved into what we now call the Joint Commission. It left our organization in the 50s. But that tradition is what we've carried forward today. Commission on Cancer is almost 100 years old itself, and that was one of the first diseases where variability in care, creating consistency in care, was important to the American public. They wanted to know that when they went to a surgeon, they were getting somebody who was practicing according to a set of standards. And that's the tradition the organization that Dr. Nelson oversees now has maintained. The most recent element of that is the surgical care standards. And if you think about it, as surgeons, we're trained by our peers or our professors. We learn what they learned, which they in turn learned from somebody that taught them years before. But the use of evidence in a traditional way of creating the basis for how you provide an operative technical care is often more based on experience or the learning that you were subjected to as a resident rather than evidence. So with the ability to have clinical trials and have evidence that is published and validated and then incorporated into standards for care, that's going to do several things. It's going to, first of all, revolutionize the way we think about a technical operative intervention. So there are going to be specific goals that are laid out that are known to correlate with better outcomes. And we're going to teach people how to do that. People are going to hold themselves accountable to it. We're going to create a documentation system to show that we've accomplished that when we work with a patient. And all that wrapped up is going to provide better patient care for surgical patients. This is truly going to lead the way to how we do surgery in the future.
Really, you're describing the beginning of a real quality improvement for surgery itself, a program that could actually look at how to make surgery better by picking out those items that really make a difference and then making sure we work on those to make a difference for cancer care.
Yeah, and I mean, I think in my mind, it's even bigger than that, Heidi. I really believe that this program that you all have developed, and it started with the standards manuals, to do the exercise of determine from the literature what the best practice is. Once that's done, then we're very good as an organization in implementing things like that. And what does that really mean to a patient? It means rather than you come to a surgeon and rely on their expertise, which we certainly all do, or their training and background, which we certainly do, we're now also going to have an objective set of criteria that as a surgeon we can measure ourselves against, as a patient they can measure us against, and as a community we can agree these are the determinants of better care that leads to better survival in the terms of cancer or less recurrence or all the things that are important to patients.
So excellent thoughts. And why now? I mean, is it just because we have the evidence right now, or are there other things that you think really brought this to bear now and not earlier?
I think it's a convergence of a lot of forces. We're not there completely. We have many quality programs that we have articulated that have not been widely adapted. It's taken us 10 years to get people to adopt things like the NSQIP database. And even now, we're not as far out as we'd like to be. But I think it's a combination of having the data, so doing the studies, having the data be easily translated and communicated to people that are involved, having a way to measure those results so that we're transparent about how we're actually doing things. And that's really the movement that you and I have both seen in our career in the last 20 years or so, of moving from sort of eminence to evidence. And, I was taught the way to do things 35 years ago, and I accepted them because they were taught to me by respected people. But I've also learned that some of them were wrong. And it's much better to try and think about how could you design a clinical trial to prove which way is better and then adopt that as practice. So we are really moving toward a much more scientific approach to the care we provide for patients.
Also, do you think it's because we can put these tools actually to document this in the electronic health record, which of course we now all have, and that the younger people can use this as sort of just-in-time information to sort of remind them of what it is they should be paying attention to? It's kind of it's a feedback loop, if I may say that.
Yeah, it's a checklist. It's a high reliability concept. When Mr. Lindbergh flew across to Europe, he had a checklist in his cockpit. People don't talk about it, but he reminded himself to look at his watch every few minutes to assure that he was awake. He had a way to check the amount of gasoline he had left in the plane because he knew where his vulnerabilities are. So if we design in an operative intervention and how many lymph nodes we need to take to adequately excise the tumor and provide the best care. If we have landmarks that we can agree upon are the dissection endpoints to which you have to go, and then we can dictate those in our operative note. If we can take a picture of them or show that as evidence that we got there, it's going to make us all be much more precise and better based on evidence. So all of this is really moving toward a higher state of high reliability in my mind, and patients benefit from that.
Yeah, well, let's pivot to talking about patients, because that's really a part of the mission of the college is to make care better for patients. And do you think this will benefit patients, and how might it benefit patients?
Well, let's take a common operation, colorectal surgery. Dr. Nelson is a colorectal surgeon that was chairman of the Department of Surgery at Mayo Clinic. So, you can't get much more in terms of eminence in terms of her ability to do that operation. We know that mesorectal excision improves at least recurrence and perhaps also improves mortality. We also know that not everybody knows how to do it. So if a patient knows that they're going to a surgeon that's been trained to do it and follows a set of steps to document that they've done that, then the patient knows they're dealing with a surgeon that's going to give them a complete treatment. So as we get better with this kind of thing, patients are going to have that knowledge. They're going to know. They're going to see published reports. So patients are going to benefit not only by knowing that they're entrusting a physician that they should trust, but they're also going to benefit from the improved results. So many ways patients will benefit.
What do you expect we're going to learn from setting standards and monitoring them? We touched a little bit on this is really kind of maybe a technical version of surgical quality improvement. You agree with that? Sounds like. Other thoughts on that about what we're going to learn?
Well, over time, we'll learn when we were right and we'll learn when we're wrong. We'll study it. We'll continue to be able to evolve our principles of care based on that feedback loop. So it's ultimately implementation of clinical trials into practice, the monitoring of practice, determining when failure has occurred or improvement has occurred, and then adopting that more widely. So it's that loop, and we're always trying to use that to improve care.
Absolutely, yeah. This will be a perfect opportunity to kind of get into that kind of a loop or cycle of improvement. Are there any other thoughts you'd like to share about the future role of operative standards? Is this here to stay and going to be expanded? Any other thoughts?
Well, I think the other big impact it will have is on the education side. If we can demonstrate that these tools, both the definition of the standard and then the implementation of the standard through the ability to report it and measure the tissue that's taken out for achieving that standard. So the pathologic validation, the radiologic validation, and then the operative report validation. Those three pieces, determining whether we did an operation correctly, that will become the forum for education in the future. It will not be my opinion versus your opinion. We will have some areas where we still may use a different suture or have opinion about certain things, but the core of the operation, you and I will agree, this is the way you do it, and we will both learn how to do it the same way. And patients, again, benefit from that.
Absolutely. I have to imagine that laparoscopy played some role in thoracoscopy, and all those video enabled technologies really allowed us to see into the operating room, which before was a black box. If you weren't there, you didn't know what happened. So I really think this is in large part because of the success of video assisted surgeries and actually being able to see what happens. And of course, the college supports a lot of that type of information sharing. And I think that's another nidus for communicating the specifics and the details that matter to outcomes.
Well, and I think we're all going to be much more open to having our performance evaluated. An artist, a pianist, an athlete cannot get better if they don't have somebody that cares about them, but is objectively helping them shape their performance to optimize themselves. And we've traditionally just assumed once we learn it, we're good for life. And we all know that that's probably not correct. So this will give us a tremendous opportunity to learn from each other, learn things that make things more complete, more precise, more fluid, and that all translates to less complications. So I think as we take these principles and use them as the basis of how we define a good operation, and then use them for teaching and then for coaching ourselves or constantly striving to improve, we're going to create a whole different culture than we've traditionally had.
Excellent. Yeah, those are forecasting the future. Um, it'll be our job to deliver on that vision, but we share the vision. Um, Dr. Hoyt, anything else you would like to share?
No, only again, I'd like to congratulate you and your predecessor and the team of surgeons in particular that have developed these operative manuals, because have become the basis of a new wave of accountability for what we provide to patients. And it wouldn't have happened without all those people involved. And I just want to congratulate all of them.
Yeah, they're great teams of people who give of their time and their expertise and their knowledge to move the field forward. And I want to express my gratitude as well. Thank you, Dr. Hoyt, for taking some time to share with us your thoughts about the Cancer Surgery Standards Program, the latest program in the cancer surgery and the cancer programs of the college. We're really grateful for all that you have done to support the programs and to come out today and to share your thoughts as we launch this program. Thank you so much.
And thank you for your leadership.